Yes. So there's two components to that. One is they're separating people and decreasing the number of people you meet, which is obviously the social distancing. Then the other one is the efficiency of transmission, trying to decrease that by these other methods as you just outlined. Yeah, so if you can see it as two components, I mean, the lockdown, if you don't meet anybody, then you're not going to transmit it. So there's two components to that, which, as you're quite right, they seem to be rather simplistic, but they do work.
So just outline to me how you see it playing out and what the factors are.
Well, shall I go back to what I've done and what the conclusions of some of my work is and the relevance of that to COVID? Is that a reasonable way of going?
Absolutely. Perfect.
Okay. So initially I set off a few years ago to try and understand TB transmission because we have more TB today than we had 100 years ago. And it seems to be a fundamental of TB, of any disease control, that you want to stop people catching it. And we never really put a focus on that for TB, although we have a tremendous focus on that for COVID-19. And I think the reason is that the response time from getting infected to disease is very short. It's in days with COVID, whereas with TB, it's longer. And that always confuses humans. So generally, people have, for the last 140 years, have felt that TB transmission was only done by the most symptomatic people. And you can see, again, all the parallels with COVID. And the reason for that, I thought, was one, it could be true. The other one could be that you can identify patients with a test which isn't very good. And our sputum test is about 50% sensitive. And then we didn't have any way of measuring aerosols. So we made up the story. So what I thought is, well, let's try and see if we can apply a bit of technology to this. And firstly, try and capture very efficiently what's coming out of people. And that sounds simple, but it isn't, because a cough, which everybody's infatuated with cough, comes out at about 40 meters per second. So to capture that is very difficult. If you cough into a bucket, you'll feel the rebound because the air at those is incompressible. The wave comes straight back at you. So it's not an insignificant challenge to be able to capture that. So we overcame that. We capture coughs coming out at those sort of speeds, and we can capture every other respiratory maneuver, which is less than that. And then we combine that with, let's find a way of detecting the organism which is much better than all the previous ways. So we then developed with colleagues in America a probe which could identify a single live organism. So we could see that it was live and was picking up these probes, and we could look at it on the microscope. So the combination of those changed our whole thinking about TB. So instead of thinking TB, only the most infectious people, the smear positives, are transmitting, we can now identify organisms in a short period of time from everybody that's got TB. And obviously it varies from high numbers to low numbers, but that changes the whole story. So what that then gives credence to is it possible that under certain circumstances, people who are not as infectious can transmit this disease? And then we come to the question of how much air are people swapping with each other? And I would guess, William, you and I are probably swapping about 25 liters of air with other people per day. If you were in Polesmore prison, you would be swapping 2,000 liters with other people. So under those, so what we're now saying is, under poor social circumstances, people who are not as infectious and couldn't infect if you're only transmitting a little, exchanging a little bit of air, could be infectious. And we think that this is probably what's been driving the epidemic in South Africa amongst our poor populations. So that's the background. And then you then look at the parallels with COVID. And the modeling papers are now coming up and saying, well, we think about 80% of cases are probably related to asymptomatic carriage. And that's because this is a relatively short period of time. People can work this out. Well, I believe the same thing for TB, that we can only identify about 30% of TB in our country where we can link it to someone who infected them. So again, I think they're both airborne diseases. I think we can learn something from both. They're not identical, but we can learn some messages from both. So of the work that I've done, probably if I were to encapsulate it, I'd say the one thing that we have found is that the periphery of the lung, that's the peripheral airspace is where pneumonia takes place, particles being produced there and organisms being exhaled there are totally independent of cough or sneezing. So then that's one message. So then we have to see how can we apply those to COVID. And COVID, a lot of our work and our ways of trying to interfere with transmission are based on flu and extrapolating from flu. Well, flu is an upper airway disease. And there is no doubt that if you exhale at very fast rates of 40 meters per second with a cough, you will vibrate all the upper airways from your voice box to the nose and your pharynx. So you will get a sample of upper airway particles. But if our data is looked in, just taking deep breaths can actually produce as many organisms, identical number of organisms from periphery of the lung, which is what we're doing with TB. So then you look at COVID and you look at the sensitivity of the tests that we're using. And there was an interesting comparative test done in China, and they did a throat swab. And I think they found it was between 20 and 30% sensitive. And they did a bronchoalveolar lavage, which is taking a sample of peripheral lung fluid, which is what we do. And that was 93 to 97% sensitive. So it seems, if you apply a sort of little bit of intuitive common sense, that if you want to diagnose a peripherally lung disease, then a sample from there is appropriate. If you want to diagnose an upper respiratory tract infection, then swabs of the upper respiratory are appropriate. But the problem is that this disease does both. It affects it presents with some people with shortness of breath straight away, and that would indicate that they've got lower lung disease. And in China, they did a few cuts on a CT to make a clinical diagnosis, and they said, well, this is our clinical definition. But both of those were peripheral lung issues, and those are the ones that they probably did the BALs on, whereas other people have an upper respiratory tract infection. So this, you have the assay which has a certain sensitivity, but then you have which are the samples that you should be looking at. And my quick answer to that is you should be looking at both. You should be looking at upper and lower. And that's what we've developed the technology to be able to do that.
Now, when you say looking at upper and lower, does that mean two kinds of tests or the same test but with different samples?
You're pretty sharp on that. So what I'm thinking at the moment is that I could, for instance, just get someone to give me 10 deep breaths followed by 10 coughs, and we would get upper and lower respiratory tract sample. Very small quantities. They're in nanoliters that we collect. We measure all the particles, but we think that that would be a great way of getting a sample, and we want to compare that with the throat swab. And we have lots of evidence there to suspect that we will be much more sensitive than because we'll be picking up both upper and lower.
Robert, at the moment the test is a throat swab, am I correct, for COVID?
That's the one that generally, you can do a nasal swab. In China, they also looked at sputum, and it seemed as though the peripheral lung was the highest sensitivity, the throat swab was the lowest, and sputum was somewhere in between, and a nasal swab was better. The problem with extrapolating from those data is they may well have been doing different tests on different sickness, levels of sickness of patients. So they probably only did the invasive BAL on the sickest patients, whereas they probably did the upper respiratory swab, which is much easier to do, on the less ill patients. So there's always biases in these unless they're controlled studies, but it's interesting data to sort of give us an idea of there are two things. One is the sensitivity of the assay itself, and the other is, are we doing the appropriate specimens?
So should South Africa be looking at a different kind of test, and what are the implications of that?
Well, testing has changed rapidly by the minute. So if you look at what's becoming available, there is a test coming in, I think, from Abbott, which is a serological test. That's a test that's looking for antibodies in blood, which is a totally different type of test. It's coming in at, I think, I don't want to be pushing them as a salesman, but it's coming in at a reasonable, affordable cost. And that test is a totally different way of diagnosing the disease as opposed to respiratory samples. So what I've been saying is relevant to respiratory sample testing, but there will be probably blood tests coming in. I know there's another company making similar tests, and they're all racing like mad to get these things out. But they give us a slightly different view. So what that's doing is looking at an immune response to the organism, a little bit like our skin tests for TB. And that would tell you, well, how prevalent has it been in this community? How many people are susceptible? How many people are no longer susceptible? And that intrinsically is going to be the control of this epidemic. The epidemic will be controlled when the number of people susceptible to it in the population drops. And that's either because they've had the infection or we've developed a vaccine in order to produce that immunity. So my discussion on the bioaerosol and the origins of the sample coming from where the organism is related to respiratory sampling. And the test that we've been using for that is so-called PCR, which amplifies the RNA, the genetic code of the virus. That's the sort of standard that we're trying to increase the numbers of. And it takes a long time to get a result. The blood tests may well, they're on lateral flow devices, which is a bit like a pregnancy test. So those would give answers within minutes or certainly less than an hour. Whereas the RNA tests are at the moment taking a day or two, but there are cartridges being made by many companies around the world and being made rapidly, which will do it within an hour or two. So this is a rapidly changing field, and we need to make an idea of which are likely to be the most successful, and then they need to be scaled up, because essentially we've got two ways of tackling this epidemic. One is the social distancing and decreasing the efficiency of transmission between people, and the other is actually finding out who's got the disease, who's transmitting it, and targeting towards those people. And that'll probably be a combination of respiratory sampling and blood sampling.
And the point that you make about that your research has shown it's not just cough or a sneeze, but it's actually just breathing that enables this aerosol transmission. What are the implications of that for practitioners? There's all this, there's this discussion at the moment about whether doctors should be seeing people at a first contact point, or whether it should be a tele consultation and then people channeled accordingly. What is your view on that?
Well, I think it's incumbent on the medical profession to deliver their medical care. If they can do it efficiently remotely, then that would be preferable. I think America's hit this crisis of personal protective equipment, and they've run out of it, and they're using masks multiple times instead of once. To my mind, I'm quite taken by the number of medical people in China. The first person who recognized the disease died of the disease. So there is transmission taking place between patients and staff that actually know about this. So I think giving them the appropriate and proper personal protection is key with personal intervention. So they should not be using inadequate masks multiple times that are meant to be used once. They should be in well-ventilated areas, and if they can do it remotely, that's fine. So my view is that N95 masks do need to be used and given to protect our medical staff, because they're the front line of our ability to cope with this epidemic. And unnecessary consultations are obviously need to be minimized. And if things can be done remotely, that's also fine. But I don't think that's ever going to be a total substitute for meeting patients and interfacing with them at close quarters. And under those circumstances, we need to give the best protection to our medical staff as possible. And you see that even in the richest country in the world, in the US, they're using inadequate masks multiple times because they don't have enough equipment. So there is an urgency, to my mind, to get testing and protection equipment for our medical staff.
But when you use that staggering comparison of 25 liters a second if we sitting talking to one another, but in Posmo it would be about 1,000 times higher than that, or 100 times higher than that. So basically sitting in a minibus taxi is going to be a bit like being in Posmo prison.
A little bit. I have actually looked at that. Interestingly, there are two components to this. One is the crowding, number of people you've got, the amount of air that you're swapping, but time is also a big factor. And it so happens that in minibus taxis, they open a large part of the side of it at regular intervals. And the time that people spend in minibus taxis is relatively short. They spend more time in train travel and bus travel. And obviously the big risk is, if you're in a minibus taxi going between provinces, that would be very, very high because the total amount of air that you will have exchanged with other people would be very high. So it's a little bit complicated. There's a number of people in the space. There's the ventilation of the space and the time that you spend in the space. So three components really. Now in prison, everything's against them. They're crowded, there's no ventilation, and they're there for 23 hours a day.
Yes. Tell me about ventilation, what the factors, windows, air conditioning, how does that all affect the transmission rate?
Well, again, there's not a lot of experiments directly on this, so we're sort of extrapolating from other experiences. But if we had two forms of transmission, relatively large particles, which can be accelerated in a cough at somebody else, then ventilation is not going to make as much difference to that. It's preferable to have it, but if there's direct large particles being extruded at very high rates, that's where the 2 meter rule comes in. If we're talking about small particles that can remain airborne for long periods of time, then ventilation makes a massive difference to that. And then air conditioning units vary in different systems. They can be HEPA filtered. So if you were to buy the top of the range Volvo, I went around their factory looking at their air units, they recirculate and filter air. So there are different levels of safety for air conditioning. Just recycling air is not a good idea, and cooling it. The amount of fresh air that's coming in that's diluting the sample is important, and that can be diluted by many ways. It can be diluted to some degree by ultraviolet light. Yes. That almost makes it the same as ventilation. You can put fresh air from outside, or you can filter in the air conditioning system. So they are all ways of removing the particles from the air, and that obviously has some benefit. The next thing is how infectious and how is the particle, how able to survive in the environment is it, and how many are being produced by individuals per litre of expired air or whatever it is.
Robin, does that mean that
can I just go back one thing, just to, because it may get, you said just breathing. Now, I've been very careful. So what happens is the particles are produced in the periphery of the lung when, because they close down as you breathe out, and then they open up and pop because they're covered in a sort of detergent. And that's not necessarily, I wasn't saying normal breathing. If you breathe very slowly in and out, then that doesn't produce a lot of particles. But if you take a deep breath out and then a deep breath in, that will produce the same as a cough. And in fact, when you cough, you normally do take a rapid inspiration just before. It's that which produces the peripheral lung particles. So I don't want to scare people that just normal tidal breathing, and to some degree speech, because you modify the speeds when you speak. So speech and tidal breathing are not deep breathing and coughs are the same. So it's just illustrating that a cough is not necessary, that the breath before the cough is probably what's producing it. Sorry, that was just to sort of clarify that.
No, sorry. To come back to this thing of air movement. So
Yep.
A desk fan is probably not a wise thing. An open window is preferable.
Yes, open windows are quite interesting. That if you open a window on one side of a building, you don't get you get hardly any ventilation. If you open it on both sides of the room, then you get cross ventilation dependent on the wind velocity of the side that's open facing the wind. So it's highly variable. In the old days, we used a lot of thermal ventilation. So I don't know, when you were in old-fashioned classrooms, they tend to be very tall and they had windows up at the top. And that's a different type of ventilation, which is due to the heat produced by individuals, has a sort of Venturi effect of moving up and taking it out. So ventilation is something which we've sort of forgotten about over the last 100 years. We now build buildings because of their cost effectiveness and their heat efficiency. But in the, if I went back to the 1920s and looked at ventilation in New York classrooms, and they were excellent. But they had these high windows and there was an emphasis on ventilation. Hospital wards were so-called Nightingale wards, were very high ceilings. And that, of course, increases the volume and dilutes the particles in there. So it seems as though we have lost a lot of that knowledge and ignored it to our peril, because I think that's not good for respiratory transmitted diseases.
You spoke of the role that ultraviolet radiation can play in this. There's been the speculation that one of the reasons that Africa has not as yet recorded such high rates of infection because of the climate and the heat and the sun. What's your view on that?
I think that it's an interesting theory. The data at the moment looks as though that's not the case, that this virus may be less dependent on those type of things. The other thing is, I believe that most of the transmission is taking place indoors. That as long as you're not too close to people outdoors, it's not going to, the small particles aren't going to transmit between people. Infectious diseases usually are related to indoor. And obviously weather changes our patterns of behavior. We tend to close the windows on our cars or minibus taxis, and we tend to crowd together inside. This virus, at the moment, there's not enough data to have a lot of hope that climate will make a big difference, but time will tell. People are looking at it, but the feeling is that it's probably less impacted by environmental conditions than the seasonal flu. But really, it's been a little premature to either put too much hope on there or to be too pessimistic about it. But we will see in the next few weeks what happens in South Africa. And if we follow the trajectory of the countries in the Northern Hemisphere, so it's speculative, but I don't think we should not do everything we can in the meantime on the hope that, oh, well, it will get better, it won't transmit in our... So, and the other thing is we are coming into the flu season anyway in the next 2 or 3 months.
The expectation has been that because of South Africa's high HIV and TB prevalence, it's going to be particularly vulnerable. I've heard someone suggesting that it might be that the opposite, that people who are on antiretrovirals may in fact be less vulnerable to COVID-19. What's your views on that?
Well, I think as a nation, one of the things we've got in our favor is that we're a relatively young population, much younger than Italy, for instance. I think a very large percentage of our population are under the age of 7. So the impact at a national level could well be much less. And then the factors that you say, HIV, in Europe, they've been looking at that fairly carefully, and it doesn't seem to be a major factor. You're postulating it could be a protective. I don't think we've got enough data to say that, but the feeling is that HIV individuals on appropriate antiretrovirals are not a particularly excessive risk compared to the rest of the population. Obviously, age is probably more important as your risk. The TB one is fascinating, and it's something that really concerns me. There was one little bit of preliminary data from China to say that there may be some link between the two epidemics, and certainly I think that it's an interesting area of research to see very early on if there is a link between those two, because we do have the highest TB rates in the world, airborne disease, and it'd been very important for us to look to see what the prevalence of COVID is amongst that group of people. And the other problem is, of course, they're presenting with almost identical symptoms. So you get a fever, shortness of breath, and body aches. And we have to distinguish between TB and COVID. And I think the logical thing is we're going to have to get the tests to test people appropriately for TB and appropriately for COVID, because they may have either or both. And that, I think, is potentially something that South Africa needs to look at very carefully and is in a better position to be able to answer.
What's your gut feel how it's going to play out in South Africa? Are there things that are not being done that we should be doing? Are we doing some things incorrectly?
I think the big thing is we're not testing enough. There are logistic and reasonable reasons for that, so you can't point fingers, but I think that is a major emphasis that we should be targeting. I think there are some things that perhaps weren't thought through. The secondary consequences of laying people off, and I'm aware that the taxis going between provinces were full of people. That's what we did in 1918, and that's why we had double the mortality rate that happened anywhere else, because we disseminated the virus very rapidly. So I think that we should have protected the rural areas from the epidemic in the cities rather than sending relatively young people back and forth. I think the emphasis is on protecting older people. Is our key thing. I think on the positive side, we have a very young population. How effective distancing strategies are living in very poor conditions, I think there's no experience in the developed world about that, and I think those are the things that would concern me and that we should be particularly focusing on. But I think my highest priorities are to protect the elderly, and if they're sitting in the rural areas, we should have given them supplies and kept them there. People in old age homes, I think we have to protect our healthcare system, because it is going to be stretched. And we're not the wealthiest of countries, we're a middle income country. So we have to preserve our resources, and our medical staff are a particularly important resource. And then the effectiveness of distancing strategies, I think to some degree, the reason we use them is because we don't, it's such a blanket thing. It's because we don't understand and can't identify the sick and the transmitters. So therefore we take the whole population and try and apply something which seems intuitively the right thing to do. There are always secondary unforeseen consequences of that. When you close a school, we've been looking at nutrition changes. Kids were getting their meals. Are they all going to go and transmit the disease to their grannies? Those are all the difficult things. But on the other hand, I think that having seen the explosion of the epidemic in other countries, it's not unreasonable for our leaders and politicians to try and do the fastest, easiest thing to do. Will it always be, in retrospect, the smartest thing? Could it have been refined better? I'm sure that's always going to be the answer is yes. But no, I'd support the idea. The concept of flattening of the curve is interesting, but we're really trying to buy time for our health system and for our old people to be able to get a vaccine in maybe 18 months and not be infected in the meantime. So it's complex. It's easy to throw stones at specific idiosyncratic bits of the program, but I think in principle it's the right way of going.
Thank you very much, Robin. We have had a couple of questions already. There's one from an Italian doctor, Emanuela, who's in Mozambique working for an agency there, and also Robin, a dietitian, both going around the topic of masks. Firstly, there's a lack of clarity. The CDC says the public should wear masks. I don't know where the World Health Organization stands on it, or the Department of Health. So should the general public be wearing surgical masks? And since there's a shortage of surgical masks, the point that Emanuela raises is, can one use homemade masks as long as one changes them regularly and they are properly washed? And similarly with surgical masks, do they demand a daily change, or can they be properly reprocessed so that they are again sterile and usable?
Well, I think the first point is if we have a limited supply of high quality N95 masks, they have to be prioritized towards the healthcare workers. I mean, in Italy, I think 10 to 20% of the epidemic impacted healthcare workers. So they are a particularly vulnerable group. We need them to carry on working, so we need to focus sophisticated masks towards that population. As far as the data, it's always interesting that whenever one organization comes out and is definitely against it, and another organization comes out and is promoting it, it usually is indicative that we actually don't know what's going on. And I think that's part of the reason why we're getting different answers from the CDC and the WHO. I think the data that's coming out is that wearing a mask is certainly very good as a philanthropic activity. So you're not going to cough your larger aerosols at other people. It's going to be captured. The question is, how safe is it for protecting you against large particles? Probably reasonable. Protecting you against small particles, less so. But any protection is better than none. And if everybody wore masks, it certainly would decrease transmission because you won't be donating your organisms to other people without knowing it. So I would support masks. I think there's some data coming out of design of masks with other materials. And that's the big variable. So are you using 2 layers of cotton? Can you get access to, there's an interesting material that's in large supplies used for sterilization of surgical equipment. And that has been designed into a mask by the Florida anesthetists. So it's a rapidly moving field. I would personally be supportive. I can't see the downside. The fear that it might siphon off equipment from the people who need it, I think it just has to be dealt with. But there is a protective degree of protection from that, and I would be supportive of it.
Thanks, Robin. There's another question that actually flows from that. It's from Avron Heyman in Cape Town, a GP, who says that the current practice that Dr. Heyman is following is to consult all patients using a Perspex visor, and then also to use one of the only N95 masks that he's managed to scavenge, and which he then tries not to touch the outside of the mask, and is wondering if he could microwave them for continued usage.
I think moved a little bit out of my field of expertise on the microwavability of different materials. I have a sort of vision of the whole thing melting, but I think you can swab it down with alcohol. You could dip it in, I think, 2% bleach. It has to be not thermo softening to put into the oven for 30 minutes or into a microwave. So I'm afraid I couldn't give a recommendation to use the microwave. I have a sort of feel that it might not be a great idea. But if he's got access to alcohol, then swab it down with alcohol. that would be pretty good.
A question from Marcus. What infection control measures would you suggest in informal settlements? That's Marcus Lowe from Spotlight.
That's interesting. And I think that's where the role of personal masks, first of all, if we can get the right material or substitute materials into the townships, there are many skilled seamstresses that could make masks. So it would be a question of education, giving them sort of some quality control. You can hold them up to the light to see if light comes through, for instance. But I think that's something that could be scaled up very rapidly and would create local employment. I think the more sophisticated medical interventions are going to be, unfortunately, not available. So then we come back to social distancing. I think that's has practical problems when you're living very close to other people. I think I am concerned about the taxis and crowding of people in taxis. The worst sort of mixing that can happen is so-called general mixing, where you meet different people each time. When you're in your own home, you meet the same people each time. That's called associative. And as far as an epidemic is concerned, it's the generalized mixing. So if you go to a big meeting with a church meeting with hundreds of people, or a scientific meeting with hundreds of people, that's the big risk. So you need to avoid those type of meetings. But as far as a sort of medical intervention, I would be supportive of using masks on a wide scale.
A question from Professor to you from Stuart, who says, what is your opinion regarding the possible protective effect from BCG immunization? And what would your advice be to President Ramaphosa after the 21-day lockdown?
So that's a fascinating question. BCG is a complex intervention. It was used in the UK from 1940s, I think, until as late as 2006 or something like that. So there's a whole cohort of people who've been infected, been given the vaccine. I would expect that Boris Johnson would have been given the vaccine, and he's suffering from COVID at the moment. So it's not going to be, it's going to be more of an epidemiological interest. I don't think it's going to have a role of suddenly scaling it up. The ability to manufacture it's going to be not that easy. The next thing is it could be a two-edged sword. Part of the problem from the disease is the viral replication itself, but it does appear that in some patients an over-exuberant immune system may be partially causing respiratory failure. So it's an interesting observation. I don't think it's going to be a realistic intervention that we can do, but it would be interested to see whether some of the age distribution of the disease and severity of the disease was historically related to exposure to that. In this country, all children are given it soon after birth, and if it does have protection effect, that would really be one of the positive features for us.
Robin Janella asks, the World Health Organization and the Ministry of Health are telling us that this virus is not transmitted as an aerosol, but only as droplets. Kindly discuss the evidence for transmission as an aerosol.
So that really comes down to understanding the nature of particles. So large particles have large mass, a third power of their radius, and they have momentum, and that's why they can be projected over long distances by coughs. And because of their size, if you looked for the virus, you're going to find much more virus in big particles than you would in small. On the other hand, as I sort of pointed out, peripheral lung particles can be produced by deep breathing and other respiratory activities. So probably both are going to take place. And the one is easier to deal with. Any form of mask is going to take out the big particles. But we still have the problem that 20% of healthcare workers in Spain and Italy are getting infected. That would seem highly unlikely from large particles. So again, when a lot of people are making these statements and understanding the mechanisms behind are probably more important. So the quantity of transmission from one or the other is probably going to vary on the site and the environment or conditions they're in. But I would come out and say there is definitely going to be some transmission from small particles. And that's why N95 masks are used in invasive situations where aerosols are likely. Aerosols are only small particles, less than 5 microns, remain airborne for long periods of time. And obviously, if it's a well-ventilated area, it's not going to be a problem. If it's not a well-ventilated area, then I think it is a problem. That's another interesting one that came out is how did the tiger in the US get infected by its handler? It's unlikely that they cuddle together very much, and would imagine that it's that. So there are some puzzles on transmission. So we don't understand all the mechanisms of transmission. So we're working from epidemiological data and from mechanistic data that we have.
Can you clarify something that you spoke of earlier, and that's the difference, the testing for upper and lower respiratory testing? Which one of the listeners asked, did you say is more sensitive?
The most sensitive was the invasive bronchoalveolar lavage, which is a way of taking a sample from the peripheral lung. But as I pointed out, you only tend to do that in the sickest patients. So these are obviously patients with respiratory disease, peripheral lung disease, and therefore that would be the appropriate sample for those. Interestingly, for TB, it's also the most sensitive. And the research that I've been doing was a way of capturing that fluid without having to be invasive. So, yeah, does that answer the question?
I think so, yes. Robin Siders asked, do you suggest healthcare workers wear N95 masks for all interactions with patients? The World Health Organization guideline regarding rational use of PPE suggests N95 masks should only be used for aerosol generating procedures, and surgical masks would suffice for other interactions.
So again, one of the words in there was really related to resource allocation. So it's a logical thing when we've got a shortage of high efficiency mechanisms. Again, I'd point out that there is a great failure rate of the current strategies in Italy and in Spain. So there has to be a rational use of resources, but you're titrating the level of medical sophistication with the risk, and there is never a zero risk. So it looks as though in South Korea, the ambulance workers and the nurses use facial shields with filtered air going across them. Could we do that here? No, we couldn't, because we don't have the equipment. So a large amount of these recommendations are coming on what is practical at the moment rather than what is optimal. I would suggest that the optimum is to use the maximum effective device that you can afford. And that's why we finish up with some sort of practical recommendations of surgical versus N95 masks. And community cloth masks. I mean, it's basically titrating what we have against the numbers and the need.
Let's come back to those cloth masks. Two aspects. The one is, can they be cleaned and reused? Well, obviously they're going to have to be cleaned and reused, and if so, how does one do it? And then Erica Lazarus says that there's some recommendations for cycling masks, using a new mask on day 1 and then day 2, and then again on day 6, begin using number 1 again. Any views on that?
It's an interesting strategy. Again, what we're doing is we're titrating the utility against the availability. There's been a few studies on survival of the virus in the environment, and it seems as though after a few days it doesn't survive well. So that would be an interesting thing with the cycling of masks. I think that hot water washing is suitable. Putting things into an oven at 120 degrees for 30 minutes would be soaking in chlorine in bleach is probably going to destroy the rubber and a few other things. But there are many ways of cleaning, and I probably think that normal washing would probably be, hot water washing would probably be satisfactory. But it's an interesting suggestion of the cycling, because then you're taking advantage of the limited survival of the virus on materials. And if you know that it doesn't survive for more than 72 hours, then having 4 masks rotation would work. But I'm not sure about that data.
Erika Lazarus asks, if masks are not used by everybody, could they become a fomite? For instance, asymptomatically or mildly symptomatic non-mask wearers expel viruses which are then picked up by someone else's mask, which is then touched, pulled up, used incorrectly, and then you may as well deal with it at the same time. What about the risk of contamination from masks if touched frequently and not taken off properly or disposed of properly?
I mean, unfortunately, yes, this is a problem with all the interventions we've got. I mean, N95 masks have to be used properly. We have to train people to do it. So it's not an easy thing to do. If you have gloves and aprons, the taking off and putting on of that is important. I think to throw your hands up and say, well, you know, it could all cause damage. It could do, but I think we just have to educate people on the proper use of these and give practical suggestions of how people can clean them. But I don't think there's any evidence that the COVID epidemic has been driven by the use of masks. I think all the evidence is really the other way. So yes, there are possibilities that you could get your mask and push it in someone else's face or do something equally horrendous, but I don't think that's a reason to not use them. There's no evidence that they have done large amounts of harm at a population level.
There's a very technical question from Francois van Wyk. Is this primarily a respiratory disease? Lung expression of ACE2 receptors is less than other ACE2 expressing tissues.
It certainly looks as though it's a respiratory disease. We diagnose it by taking respiratory samples. There's been work looking at the quantitative production of viral particles from nasal swabs, and it shows that shedding takes place before symptoms. Symptoms develop and then shedding decreases. So it gives us an insight into asymptomatic transmission, but we're finding the virus in the air and in the respiratory tract, and the respiratory tract is a well-known way of spreading respiratory viruses with our annual flu and coughs and colds, etc. So yes, I think it's primarily a respiratory disease, although there's some evidence that it can affect other organs, and some of the sudden deaths that occur have been postulated to be receptor concentrations in vascular tissue or in other vital organs. But the definition of a respiratory disease means it affects the respiratory tract and is probably transmitted via respiratory activities.
Robin, a GP, Chris Lewis, asks, could a young, naive immune system be protective? And similarly, could patients on immunosuppressants be potentially, i.e. could biologicals be potentially protective?
Yes, an interesting question. My wife got her PhD on TNF, tumor necrosis factor blockade of diseases, and certainly the immune system is very complex. Sometimes it's overactive, sometimes it's underactive. That is an interesting approach of the use of biologicals. Tend to be most effective when there's an overactive immune system, and that could be part of the so-called ARDS, respiratory syndrome. The other thing that this question touches on is the age distribution, and generally it seems as though young children respond to many of our common illnesses in a different way from adults. So that if you get chickenpox at the age of 5, you have a much more benign illness than if you had it at the age of 25 for the first time when you finish up on a respiratory ventilator with chickenpox pneumonia. So there is a difference in age responses to diseases. TB is lethal for very young children, is fairly innocuous between the golden age of 5 to 14. So there are age responses. On the other hand, I think that the age distribution of viral diseases is probably related more to herd immunity. So the 1918 flu was particularly vicious because the last 20 years before that, there hadn't been an exposure to the H1N1 virus, and that's why it affected the young soldiers and teenagers rather than the old and the young. So it's often a clue that when you see these unusual age distributions, that it may be reflecting prior exposure to cross-reacting viruses. In fact, just as a sort of aside, my son is a veterinary surgeon, and he has postulated to me that because coronaviruses are so common amongst his animal patients, that could it be that he's protected in some way? And it's an interesting question, and people are looking to see what the incidence of COVID is amongst veterinary personnel. So there's a lot of complexity to this, but age distribution, I think, often gives us some interesting clues. And I think that may be the case when we look particularly at the disease in Africa.
Robin, can we take 2 treatment-related questions? One from Tracy van Rensburg, who asked, is there any support for any specific micronutrient supplementation? For instance, she noticed some guidelines recommending high doses of vitamin C, vitamin D, and zinc. And then to the more controversial one, is there a role for chloroquine in the management of COVID-19, both as prophylaxis and as treatment?
So the vitamin story is quite interesting. Our focus on the disease is to try and stop people getting disease with the social mixing. And then when they get disease, we sort of ignore them until they come with severe symptoms, and then we throw our high-tech medical interventions at them. So that in-between part for people who've been infected and not seriously ill, they get sent home. And certainly there may be interventions and care for that during that period that might decrease the chances of progression to serious disease. Certainly, generally, vitamins and supplements are most effective in people who are deficient of those. Very little evidence that super doses of them can be beneficial, but it's an interesting window where we're actually not doing anything at that stage, and I think it's would be an interesting focus. The next one is chloroquine, which is a very interesting drug. The data is a little bit confusing in that there's been small studies which show that it might have some effect. It certainly has a level of complexity of impact on intracellular vesicles and on expression of immune markers. So it has potential, but we do have conflicting data. And when you get conflicting data, either the data is wrong or each of the studies was done in a slightly different population. So when you do the study in very, very sick patients and look sort of death at the end point, it's pretty tough to expect the drug to do much. If, on the other hand, you were looking at it as a preventative, it would be easier to show, but those studies require large numbers of individuals to do. So it's still a bit of an open question. It's a readily available drug. It's got a lot of experience in it, and it really requires a better testing with well-defined population groups, because it may work, better in some than in others. But the data, unfortunately, is not sufficient really to come down definitely on that. But it's a relatively well tolerated at the doses we're using, and there's a lot of experience, and it's licensed and out there, so it's available. So that's why naturally people will tend to use it. The data is just missing. We need more data.
Gail Nkele asks, on the Solidarity clinical trial, is South Africa part of this trial, which I think it is? Any information also on how lopinavir and ritonavir works or is thought to work against the coronavirus?
I think the evidence for lopinavir, ritonavir is not positive. The theory is that it's basically a protease inhibitor, and there is a protease phase of the life cycle of COVID. But I think there's not much positive data on that. So if you were to sort of hierarchy drugs that are going to be tested, I think the Gilead drug up front, chloroquine there, and this would be much lower down, although I think it has been added into one of the arms of the study that is being run by the WHO.
Anita Michelle asks, is the period of exposure to a shedding person likely to have an influence on the likelihood of one's infection?
Well, I think some of the modeling papers suggest that the epidemic is driven by asymptomatics. The viral shedding data showed that the shedding was highest early on. That makes it a very difficult disease to control if we have patients that we can't diagnose that are infective. So what we do now is say, well, they're contacts, and therefore we will treat the contacts differently from the general population and put them into isolation. I think asymptomatic shedding is really quite worrying because you can't identify it very easily, and you would need very widespread testing to identify those people. So it's greatly in favor of the virus and its spread, and against its control.
Another person asked whether you would mind commenting on the various agents that are being tested as antiviral agents, for example, ivermectin.
Yeah, so it's a lot of anecdotal evidence. Each of these are drugs that have some sort of rational use, and at this sort of stage, you often get a little bit of interesting data. I think that the WHO approach to use a multi-armed comparison of these studies, of these drugs, is the only real way forward. They all have some interest, and they'll have their protagonist, but we're basically swimming in a data-free zone.
And that's really what makes it so difficult for the government to know what to do. Given the fact that if social contact is limited in public and people are using masks, and I'm going to ask perhaps a very unfair question, what is your feeling about relaxing the current lockdown, or certainly how do you see it playing out? Are we being too restrictive in our initial response?
Yeah, that's interesting. Time will tell. If the politicians had not done anything, they'd be accused of being remiss. It does seem as though they were working on the premise that we would be seeing more cases. We're suffering from our testing. We're not testing enough really to be able to say that the cases have decreased. But probably better to be accused of doing too much than too little in the present environment, certainly looking at the disasters that are occurring in Europe. The theory of flattening of the curve is an interesting one, and it's based on not overwhelming your health facilities. The question, which I haven't seen in the models, is what is the area under the curve? Does the area under the curve of a flat curve, is it less? Does that mean eventually that less people will be infected with this than if you have a rapid? And we don't really know the answer to those questions. So it's incumbent on us to try and decrease mortality and overwhelming of the health system in the short term. The middle and long term responses to this, whether we will get a second wave, etc., are more complex to know. Time will tell. Certainly in the 1918 flu epidemic, the second wave in the second year, 1919, was much more severe than the first. But I think the natural instinct to try and decrease impact in the short term is admirable. What it will do in the long term is going to be dependent on herd immunity, but we don't have any way of measuring that at the moment. The new test might allow us to do that. So I think the humane response is what has taken place. And where we will go, unfortunately, we need time.
Robert, we're running out of time, but I'd like to ask you a final question. There are other questions which we haven't had time to address, and I'd appreciate it if you just look at them as some that you might be able to give a quick response to some very technical questions of availability of drugs, etc. But I wonder if you could say, Teresa Rousseau asks, could you please say something about the viability and durability of coronavirus on surfaces and objects?
Some of the data that I've looked at suggests reasonably long-term, and that would be sort of 72-hour survival on surfaces. There was an interesting observation that I think the shortest was on copper. We always tend to think of silver as an antibacterial and anti-infective, but copper surfaces seem to be the shortest. The problem is that what you're doing there is you're looking at sort of artificial survival rather than the ability to infect another person or organism. We normally rely on that closing of that loop on animal models and then extrapolate to humans. But certainly it looks as though the virus can be cultured up to a day or two on certain surfaces.
Thank you very much, Professor Wood. I'm sorry that we don't have more time for more questions, but thank you very much for participating, everyone.
Thank you, William. It's been a pleasure.